Good morning. We'll go one more time. Good morning. Fantastic. Thank you all. Well, it's a great day to be here to be able to introduce Good Samaritan. We have 3 hospice companies or agencies that we work with, that we have contract with. Good Sam is one of them, and we've been working with them for a long time. We're very pleased with that. And then if you all have another hospice agency that you want, you can certainly bring that and use that. But we thought today would be a good opportunity to begin a conversation regarding hospice, how it works. And we have these great providers from Good Sam that have been great partners of ours for a while, and we're extremely grateful to have them with us. Don't know if you all are aware or not, but Good Samaritan is celebrating their 30th anniversary. So they've been in business for a while. They know what they're doing, and they do it quite well. They're a leading nonprofit in the Roanoke-Salem area. And in addition to that, they are the only nonprofit, is this correct, Scotty? The only nonprofit in the region for hospice. So that's impressive that you can operate and continue to function that way. 30 years, nonprofit, and winner of the Salem-Roanoke Chamber of Commerce Nonprofit of the Year and the Roanoke Regional People's Choice Award. So pretty impressive work that they do, and we probably average 5 to 7 people on hospice a week, and many of these are with Good Samaritan. So we know the work they do, and we are extremely grateful for them. Today we have the opportunity to have Dr. Jennifer Easterday, their medical director. Dr. Easterday, we're really pleased to have you. And their community liaison, Emily Witt. So they will be presenting for us. Let's warmly welcome them. Thank you both. Emily, turn it over to you.
Ben, yes. I might need a little help to get started.
See, it's tech. I think Teresa's walking in, maybe, hopefully. Let's see. Doesn't feel like it has a battery. It's got a battery. Is it off? It's got a battery. There it is. Hit this one, and that should take it forward. Are we good? Perfect.
Thank you so much for having us. It is an honor to be here. And I was sharing with Ben, I've never been in a crowd of people that was so excited to talk about hospice. So I'm in awe. Usually it's breaking the ice to get to a comfortable place to talk about hospice, and you guys came with such an open mind, and so I'm so in awe, and I know Dr. Easterday is too. So I'm going to hand it over for Dr. Easterday to kind of share what makes Good Sam so different from other hospices, and it's with our mission statement.
Yeah, good morning. Thanks again for having us. Like Emily said, it's an honor. I mean, to come to talk to you about something that's dear to my heart and just to hear your stories and answer questions. It's just, I mean, this is the highlight of my week, so thank you. When Emily and I were putting this presentation together, I was like, Emily, I want to talk about our mission statement because this is what is so important to me and what sets me, it motivates me every day to do what I do. Our mission statement says that we affirm life. And I could really stop there because that's what's most important to me every time we care for a patient, every time we admit a patient, that our focus is on the life of that patient. I believe personally that every life is sacred, and this mission statement just keeps me going every day and makes me focus on the reason I do what I do. So our mission statement at Good Sam, we've had it for 30 years. It says to affirm life in the midst of illness and grief, and above all, to honor what matters most to each person and family served. So we not only honor the life of that patient, that person that we're serving, but we also honor the life of their family and what's most important to them. So I just wanted to share a little bit about that and how important it is for me and working for Good Sam and following this mission that we have. We do have hospice, as you know and you're familiar with, but we also opened a new branch. We saw a need in the community for palliative care, which is a new program for us. We're going on about 2 years having this program. So it is a program that kind of helps people before hospice in any stage of a chronic disease. So we do have another program, and we're happy to talk more about that later.
Thanks. So I was prepared to talk about how heavy hospice is. And for some of you, you may not be as eager to be here, but you're here because of another resident and a friend. Hospice is a heavy topic. I remember hearing about hospice for the first time personally as it related to my dad in March of 2016. I thought hospice was a place to go. I thought hospice was in bed with days to weeks. What I learned was that hospice was about to change my life for the better. So much so that I would leave a 20-year corporate career to come work for Good Sam and educate others so that they don't have the fear that I had when I first heard about hospice. So that they, like many of you all here today, could be excited and embrace hospice when it's spoken. So there's a lot of myths and misconceptions about hospice. It's a place to go to die. Hospice is about refocusing hope. I say that it's quality of life over quantity, and we waste quantity time often. But when you're faced with hospice and you are focused on the quality days, weeks, months that you have left, it shifts how you spend it. It is about refocusing hope. There's Medicare eligibility guidelines that specify that life expectancy of 6 months or less for physician certification. But we have many patients that exceed this. We have many patients that have been on hospice services going on years. Often getting on hospice services sooner rather than later helps to improve the quality of life, having an extra layer of care. Sometimes patients will improve on hospice, and that means that they get to a point that they no longer need hospice services. And we have a funny phrase of saying they graduated hospice. And they do. And that is wonderful to see. That happens often. But more importantly, and this is what changed my life, is that hospice is about caring for the whole person and the family. Hospice is not just about the individual that's facing end of life, but it is about the family. There's a plethora of team members that come in and embrace the family and support you in ways that you had no idea that you needed supporting. They make the journey beautiful. And hospice will also specialize in aggressively managing pain and symptom management at end of life. By definition, hospice is specialized care that provides physical comfort and emotional, social, and spiritual support for people nearing the end of life. There's a lot of people that's included in your hospice care team, and they all play different roles, not just for the individual, but also for their family members and loved ones. The team includes doctors. We are blessed and fortunate to have a full-time medical director, such as Dr. Jennifer Easterday. There are nurses, RNs, that are your care managers that see you from day one through your journey, whether it be the end or graduating. They're with you and your family every step of the way. We also have social workers. And I remember hearing social worker for the first time in my own journey of hospice and thinking, why would we need a social worker? Little did I know that that medical social worker was going to change the trajectory of the experience that myself, my mom, and my brother experienced with my dad. They're there for emotional support, and they're there to help be proactive and help us think about things that we weren't prepared for. They're there to support in areas that you had no idea that you might need supporting in. There are hospice aides, certified nursing assistants that are there to help with bathing or any light needs that's needed. spiritual care coordinators that are there to help the journey of your loved ones. They are non-denominational and they're to support any type of religion affiliation. We have incredible, wonderful volunteers, and I know that we might have some volunteers that have volunteered for Good Sam here in the audience. And the volunteers are the heartbeat of what we do. They go and they are sitting with patients and families so that a loved one can take a break and run to the grocery store. They are not allowed to have hands-on care, but they bring such comfort and support to our families in need. And we have bereavement coordinators, and they support families for 13 months and sometimes longer after the journey of losing a loved one. They like to meet people where they are. Everyone has different needs when it comes to bereavement and grieving. Sometimes our grief doesn't happen until months down the road. We're in shock and we're just going through the motions. Our bereavement coordinators are there to support, be it in group therapy, art therapy, music therapy, or just one-on-one. They're there to support you in your grief and let you know that you are not alone. We also have additional therapy services. I think sometimes people will think, oh, I can't do physical therapy or speech therapy or have different types of therapies if I'm on hospice. While that is not normally the case, we do take an individualized approach with each and every patient that comes on our services. There are going to be times that an individual needs physical therapy. They've gone from being mobile to needing a walker or a wheelchair, and the caregiver and nursing staff might need support on what does that look like. So we do offer those therapies when it meets the goals of care for the individual that is facing hospice services. Who pays? That's always the big question. You go through, I like to say that you go through life fighting insurance companies, and then you get to your end of life, and there's a hospice benefit where so many things are covered. Any type of durable medical equipment that's needed, be it a hospital bed, a wheelchair, a walker, bedside commode, supplies, and then hospice-related medications is all covered through the hospice benefit. Through Medicare, Medicaid, private insurance, and us being a nonprofit, we will never let anyone go, whether they have the ability to pay or not, without service of hospice. And sometimes it is a combination of both. So, where is hospice provided? It's not like what I thought, a place to go, except it is. So, home. We meet people where they call home. For some, it might be assisted living. For others, it might be a long-term care facility. Also, independent living, and then oftentimes there is the hospital. Wherever the patient lives and calls home is where we meet. And we have, as Ben said, incredible partnerships and relationships with Brandon Oaks so that we can do effortless care here. But oftentimes, an individual may not have their pain or symptoms managed at home or even in a long-term care facility. Oftentimes, they are having to go to the hospital to manage pain. And I don't know about you, but I know that I would not want my final days to be in a hospital. Good Sam saw a need for that, and as many of you all were asking before we started about our Center for Caring, Good Sam has started the construction of our Center for Caring that is opening in 2024. It will be a 16-bed inpatient unit for those that need respite care, that need an additional level of care that would sometimes take them to the hospital for pain to be managed. They can now go into a home-like setting. And I had to include this because this is the heart of what makes Good Sam so special. You will see the construction that's well underway of our Center for Caring. You will also see our CEO, Aaron Hosh, and the founder of Good Sam, Sue Ranson, writing on the boards scripture, quotes, and our mission statement. They are surrounding this building with a lot of love and prayer because it was a leap of faith, and our CEO will say that. It was a leap of faith that got us here because it is a big, big haul for us to get this, and we are in the middle of our capital campaign. So we will be able to offer the Roanoke Valley a place to go that will be an option other than having to go to the hospital when pain cannot be managed at home. So to take us into the different hospice care levels as it pertains to you all here at Brandon Oaks, I'm going to turn it over to Dr. Easterday.
Thanks, Emily. As Emily was saying, our hospice team goes to wherever you call home. So our team mobilizes and provides care to you wherever you might be. If you're in independent living, if you're assisted living, if you're in long-term care, and if you're in memory care, or if you're at home or even in the hospital, our team just goes to wherever you are. The care might look a little different. The hospice team, your hospice benefits, everything that you get through hospice will be exactly the same in all these levels. But as you know, in these different levels, things might be different as the needs that you have as independent living versus memory care. So we work with Brandon Oaks. We partner with them very well with their providers that are already seeing you in the facility or in the unit. And we see how we can incorporate the hospice plan of care, your needs, and the facility needs all in one. So we partner with where you are in each of these levels of care in the facility. So how to talk about hospice, it's kind of a subject people don't often talk about. When people ask me what I do and I tell them, they're like, oh, okay, yeah, thanks, and then they don't want to talk to me anymore because it's kind of a hush-hush topic. But to me, if we're talking about what's important to you, if we're talking about life, we need to talk about what you want at the end of life. We want to do what you want, and so it's important to know what you want. So hospice doesn't, like Emily said, it's reframing hope, reframing what's important to you now. So we talk about goals of care. So a lot of times our hospice team is having conversations about what's important to you right now. If something should happen, how would you want us to care for you? And there's no right or wrong answer. It's really what's most important to you. So in the question right now, do you want to go to the hospital if you have trouble breathing, or if you have chest pain, or if you have an infection? These are questions that our team talks to you about and asks you about because we want to know what's most important to you. We say, do you want your blood drawn again? Do you want tests done? It's fine if you do. It's fine if you don't. We just want to know. So talk to us. Let us know what's important to you right now. And something might be really important to you right now, but in a year from now, it might totally change. So we need to be talking about these things so we know how best to care for you and what you want. Is it important for you to remain in your home or wherever you call home? Or if something goes wrong, would you want to go to the hospital? Sometimes I talk to people that are sitting in the hospital, and they said, you know what, I've been here 3 times this month. Don't ever bring me back here. And that's reasonable. I get it. Yeah, I don't get to eat my food. The nurses are really nice, but I miss my family at my facility or at home. I just want to go sit on my porch and watch the birds. I do not want to be in this hospital anymore. Sometimes that's what's most important, and that's okay. And we want to be there to make sure that that's what you get when it happens again. We talk about supporting your family. Hospice has a great team. It's not just the nurses. It's not just medications. We have such a great team. We have, like Emily said, we have social workers that come in. We have chaplains. We have volunteers. We celebrate birthdays. We celebrate anniversaries. We find out what's most important to you, and we try to celebrate your life. I think a couple weeks ago, we even celebrated a birthday for one of the patient's dogs because she loved her dog. So, and the birthday was coming up, so we had a birthday cake and balloons, and the whole hospice team was there to celebrate the birthday of a dog. So that was kind of exciting. We talk about the words aggressive care, aggressive focus versus comfort. So it kind of depends on, again, what's important to you. If something should happen, if you should have trouble breathing, if you should have pain in your chest, do you want to go to the hospital? Because when you get to the hospital, they're going to do a lot of tests. They're going to do a lot of things to you, which is completely fine. But is that what you want? If it is, that's fine. If it's not, we want to know. So we look at what do you want? Is it the aggressive care of the hospital where you get needle sticks, you might get an oxygen mask, you get medications, you get put through an x-ray machine, a CT machine, you might get a machine that helps you breathe. These are things that are good to think about what is important to you and what you want. The other option is comfort. A lot of times I can manage your trouble breathing. I can manage your chest pain. I might not fix it to resolve to make you 20 years younger, but I can help you right now and I can make you comfortable. I can get rid of that anxiety with your breathing. If you're having chest pain, we can fix that. We can give you things to make you more comfortable. And we can keep you at home if that's important to you. We talk about planning, and social work does a lot of our planning for patients and families. We talk about writing down what's most important to you. So this could be in the form of an advance directive, a living will, a power of attorney, a do not resuscitate order, things that we can write down and talk to you about so everybody is on board when you're not able to talk yourself and express your own wishes. So the social workers work with patients and families on getting advance directives completed. A lot of times, what we'll talk about is a do not resuscitate order. So if your heart stops naturally, do you want the team to try to resuscitate it? It's a big concern as we get older because the chances of restarting our heart become smaller and smaller. And it usually means that you'll end up in the hospital. Again, which is fine, but we need to know if that's something that you want or don't want. And it's important to tell your family too. So our team can work with you on getting those things down in writing and letting your family know your wishes as well. I think it's one of the greatest gifts you can give your family is to let them know what's important to you as you age. Is it important to go back to the hospital? Is it important to have your heart restarted? They need to know, and it's a gift that you give them so they're doing what you want and not what they think. Planning for the future, we do that with our team, and then we also provide information visits. So if you're just kind of curious about hospice, we have people that can come out and talk to you and see how hospice would fit in where you are now, your environment, your community that you're living in now, and what you would get with your hospice benefit and how that would look in your lifestyle at this time. So referring to hospice, anybody can make a referral to hospice. A lot of times we get referrals from physician offices because that's usually where conversations start. But anybody, a family member, yourself, you can make your own referral to hospice if you think it's appropriate. Once we get that referral, Medicare requires us to get 2 orders from physicians. So if an order usually comes from myself and then whoever your physician might be. Once we get that order, we contact you or your family and we set up a time to meet with you and talk with you, evaluate. I look over clinical records because Medicare says, Dr. Easterday, I need proof that this patient qualifies for hospice. So that's my role, is to provide proof to Medicare that the patient qualifies. If you are eligible, which usually is a conversation between the nurse that's seeing you and myself, then hospice services will start if that is your wish. If someone comes out for an informational visit or even a hospice assessment and you're listening to things and you're like, I might not quite be ready for hospice, that's okay. No problem. We're happy to be here. We're happy to talk to you today, and we're happy to come back whenever you think hospice might be right for you. So it doesn't mean that you're obligated to sign up. It's important to know that you make the decisions. You drive the bus in hospice. We want to follow what's important to you, what your goals of care are. You make the decisions. Your family helps you. And then we show you how hospice can align with those goals of care. Like I said, you make the decisions. So if you're on hospice for a day, a week, and you say, this isn't right for me, we want to know why, because maybe we're doing something, maybe we can change the way we do something. But you can always come off a hospice. You're not locked in. You can always revoke and say, I want to wait for a little bit, and then I'll call you back if I need you. That's absolutely fine. So hospice is something that you can sign up for. If you don't think it's right, you can always stop it. So it's not locked in. A lot of people think that once I sign up for hospice, I can never come off of it, but that's not true. So hospice, hopefully we've shared that you've understood that hospice is more than helping people die. It's really about their life. We want to help you die comfortably. We want to help you die in the way that you want to die, hopefully surrounded by your family in the way that you want to be surrounded. And then with medications, with music, with your pets, with anything that you want. Again, going back to what's important to you. So we want to be the team that helps you meet those goals. And it's about helping you live out life with love. Love of the people around you, and hopefully a lot of times love from our staff. We have a lot of patients that are really dear to our hearts. A lot of nurses become very close to a lot of our patients. So we do treat you like family. It is an honor to care for every patient that we have. It truly is. And we just love the work that we do and the strong team that we have to do that work. All right.
So now we have time for any questions for Dr. Easterday. And I'll come around with the mic if you have a question. Yes.
Is palliative care a part of this first, like you have palliative care before you have hospice? Is that usually the way? Because I had a friend to come in when my husband was dying, and she just said, we want to help you, and she was with palliative care. And when she saw how bad off he was, she said, I'm going to call hospice right now. They'll come in tonight. They did. They came in, and he died the next day. Oh. So I didn't have any experience with either one. Yeah. But I just wanted to know if palliative care is working synonymously with hospice.
No, that's a great question. So the question was, do you have to have palliative care before you have hospice, and how do they work together? It's a great question. Palliative care is a new term that really we've just kind of started to briefly understand over the last probably 5 to 10 years. And it's often misused. How we use it at Good Sam is palliative care is really the start of care for somebody the moment that they're diagnosed with a life-limiting illness. So a heart condition, a lung condition, cancer, things like that. But in that state, they're still wanting to pursue active treatment. They're getting chemotherapy, they're going to their cardiologist, they might want to go back and forth to the hospital to have a heart procedure, to have a lung procedure. And we're just still talking to them about what's most important to them. Hospice is specifically the last 6 months or less of somebody's life, and it's defined by Medicare. So palliative care happens, and then hospice is kind of at the end, if that helps. Okay.
Other questions? I'll be right to you.
How do you, as a physician, determine which meds are appropriate? Do you have guidelines through professional organizations or through your experience?
Yeah, that's a good question. The question was about medications and how do I determine which medications are appropriate. Absolutely, we have guidelines, we have governing boards, I have a list of colleagues that I work with. A lot of common medications that are used in hospice are medications to help with breathing, to help with pain, to help with anxiety, to help with agitation. We also use oxygen, which helps a lot, and we also use alternative therapies that are not medications, such as music, massage. Some of the medications that I use, and one of the most common medications used for pain and shortness of breath is a medication called an opioid. So that can be a medication like a morphine, Dilaudid, oxycodone. These are common medications for pain. So if you fall and you break a hip, when you go to the ER, they will probably give you some morphine, some oxycodone, some Dilaudid, something like that. The medications in hospice are very, very low dose. I use the smallest dose we can, and we only use them if we need to. So I do have a kit that I put on every patient that we get that has that, and we call it an emergency kit. That's because when people their body starts to shut down and they're in the dying process, many, many times patients can experience shortness of breath, they can experience pain. So those are medications I want to have there for emergencies in case we have to use them. So we usually use an opioid, that's one of the ones, and another one is agitation, behaviors, hallucinations, things like that. We usually use a benzodiazepine, so that's something like an Ativan. Again, a medication that's used in very, very small doses and only if we have to use it. But a lot of times, at the end of life, as the body's shutting down, you will see some of these symptoms. So I want medications close by to manage that. So those are two medications that we use very commonly with a lot of our patients, and it is in that kit that we call the emergency kit. So there are other medications that we use. When patients come on hospice, I look at their medication list and I say, you know, you're really not getting much benefit from this medication right now, I think, and it would be my recommendation to stop it. Because as we get older, our number of pills that we take increases, right? And we're on this medication and that medication, and before we know it, we have a list of 10 or 20 medications. So when we come on hospice, the focus is comfort. I want to let you know what medications aren't beneficial right now. So I'm going to say, you know what? That vitamin D probably isn't helping you much right now. That cholesterol medication probably isn't helping you much right now. We could probably stop it. It's your decision. Again, you drive the bus, so it's your decision whether you stop it or not, but I can give you my recommendations and my suggestions. So we do go through a medication list of what medications are helpful or not. Yep.
What if there's a disagreement between doctors on medication? What if there's a disagreement about medications between you and other doctors?
So it
And
depends.
especially if I can't really express my opinion at the moment.
Sure, absolutely. So when you come onto hospice, you decide who you want your doctor to be. It doesn't have to be me. If you're at a facility, a lot of times the facility doctor will be your doctor automatically because those are the regulations and the partnership we have with that facility. So a lot of times I make my recommendations because I'm used to patients coming on a hospice. I specialized in this field, and I provide the recommendations to your doctor that you have chosen or the doctor that has been assigned if you're in a certain facility. And then we talk about the benefits, the risk, and then that doctor usually determines. But really, the conversation needs to be with you, right? Or your family. So
My mother was on 16 meds, and we finally cut it to 3.
Mm-hmm.
So much better.
Yes, and actually patients do better when they're on less medication, when we cut out the ones they don't need. So usually it's a conversation. The most important person in that conversation is you or your family speaking for you. And then whoever kind of is the primary physician there. Yeah. The most important thing is you are able to determine what you want as far as your care. Yeah.
This may be a related question, but how does and how has your service worked in a facility like Brandon Oaks, where there are several different levels of care, independent living, assisted living, rehab, long-term care, skilled nursing care, where people have medical professionals caring for them? Mm-hmm. How do you interact with those to get your goals and the patient's goals synced?
Yeah, and that's a great question. How do we interact with the partners that we have? We have really good relationships with Brandon Oaks, so we're fortunate to have good communication. Our team who is in the facility, our social worker, our nurse, mostly our nurse when we're talking about medications, is usually the one communicating what my recommendations are to the facility physicians. And we usually kind of talk back and forth about what's appropriate, what's not appropriate, and how we can make this happen for the patient. Did that answer?
I think so, yeah.
Okay.
As kind of a follow-up, how does your relationship work with a family physician, of a long-standing family physician?
Absolutely. That's a great question. A lot of people have it. I'm a family physician, so I know how important it is when I develop relationships with my patients and have had them for years. So we never want someone to give up a relationship like that they've had with their physician. So when you come onto hospice, if you want to keep your family doctor, you absolutely can. And that's perfectly fine. So what I usually do, we usually talk to that doctor and say, hey, in the middle of the night, if your patient has shortness of breath, do you want me to handle it because my nurse is going to be at the bedside, or do you want us to call you? And then we kind of see what they would like. But you can absolutely keep your family physician. I love it when patients keep their family physician because I know how important those relationships are. Yeah.
Other questions? Or comments?
My comment is probably a little out of date now, but before I came to Brandon Oaks, I had worked as a hospice volunteer for 10 years, and it was one of the best experiences that I ever had. Now, it's different now. There are different rules and regulations about physicians and all of that sort of thing. And then when I needed hospice, unfortunately, it wasn't long, with my husband, within 3 days after they sent him home from Duke, he died. But guess who was there to take care of him? And I will never forget how grateful I was for that. Or for hospice in general. You learn a lot in 10 years, even though you're not an employee. Mm-hmm. And I have nothing but the best things to say about a privately run hospice.
Oh. There's one in the back.
I had been a hospice volunteer, too, when you had that in place. One of the things that, and my husband was a patient briefly in palliative care, briefly in hospice care. But the one thing that I think is important is to use your services sooner rather than later. I think very often people don't realize that it isn't a death sentence when you enter hospice care, that it's a supportive service and the wonderful care that you can receive through palliative care and hospice care. But I think very often people wait too long as a way of, I guess it's a hard thing to accept that we're at that point, but it isn't really a death sentence. It's a supportive service. And people can, as you say, graduate out of hospice care. So I would just recommend sooner rather than later.
Yeah, absolutely. I'm glad you said that because even this week I was talking to some people and they were saying, you really don't get the full benefit of hospice until you've been on service for about 3 or 4 months. You can develop relationships with the team. You get to know your hospice nurse. You get comfortable with them. You get comfortable with the hospice doctor and the medications and what they're saying. You can get some loose ends tied up for your family. Yeah, the earlier you can get that we can help you, usually the better. Yeah.
I was going to try to reinforce that because in my professional experience with it, the sooner the better. The reason hospice gets a bad rap is because people wait until 2 weeks before they die and they to bring hospice in, and they think the reason they died is because hospice was there. But that's not the case. Another service that you provide is grief counseling after the person dies for the people who are left behind.
And that grief counseling, Good Sam has opened that up to the community. So you don't have to be a family member of a patient from Good Sam. If you don't have any connection to Good Sam, you're welcome to come to our bereavement and our grief groups.
I'm coming.
I was curious as to how you know when hospice is available or that you need hospice.
That's a good question. I think probably the best way is if you have a good relationship with your doctor to be having those conversations and letting them know, I'm interested in hospice. Will you let me know when you think it might be able to help me? The physician kind of determines the 6 months or less, and that's usually the guideline that we use. But when you start seeing changes, that things are a little bit different, and every disease is different. We have patients on hospice that have cancer. We have patients on hospice that have Alzheimer's disease. We have patients on hospice that have heart failure. So every disease is a little bit different. But when you start seeing changes that, you're like, I can't do that anymore. And I'm getting more tired. I'm getting more short of breath. I'm not eating like I used to. I'm spending more time sleeping. Start having those conversations with your family, with your physician. And you can always call us. We're happy to come out and see if, you might be eligible. Yeah, it's a good question.
Hi, I've been a physical therapist for 50 plus years and worked with a hospice group as a therapist. Probably the most rewarding job I ever had. It just was, I always left the family feeling I had received more than I had given.
Mm-hmm. Yeah, yep, I understand. That's how our team feels a lot as well. Yeah.
I can't say enough good things about Good Sam. I've experienced 2 close deaths with them of my husband and of my husband's cousin. One about almost 3 years ago now, and one just in the last 6 months. And one of the benefits I saw with Lee, my husband's cousin, who was across the street with NRC, the chaplaincy or spiritual care folks were really so wonderful in terms of bringing by books and other resources, things like that. Some days she'd just come and sit with Lee because he seemed like he wanted to talk. And that took a lot off of me, so I knew when she was there, he was being well attended. So, thanks.
Yeah, and that's it. I mean, our spiritual care coordinators are great. You don't have to be religious to use them. They're great people that are just interested in sitting and talking to you about what you're thinking at this time. And sometimes as we do get closer to dying, to death, there's a lot of questions that come into our mind. And they're really good people. They're trained in ways to help people process that as someone gets closer to the end of their life. So that's really their focus. It's not really to push on a certain religion. It's really to just help you process what's going on now, emotionally and spiritually, and also to help your family too, because they might have questions as well. So great team.
I have a question about the new facility, the Good Sam, this building. Is this a situation where if the patient feel better in a home-like situation, they have a choice of going to the hospital or going to that facility? Or kind of how is that going to work?
Yeah, that's a great question. So the facility that we're building is kind of specific. Hospice houses have different intentions of the patients that they take and the levels of the needs of the patient they take. The hospice house that we're building is more like a hospice hospital. So patients who need critical care, they're having significant trouble breathing, they're having significant chest pain, they have nausea that we just can't get under control despite the medications we're trying in the home, and they should go to the hospital, but we know their goal of care is comfort, so we want to take them to our hospital, the hospice hospital. So where we kind of initially have the thought is the hospice house is going to be more like a hospital, patients that need critical care the most. Yeah. It's off of Peters Creek and Cove Road in that area. So we picked a location that was close to the interstate, close to 81, close to Roanoke Memorial, close to Lewis Gale, and really being close to 81. We do service the NRV, so we have patients in the NRV as well, so we could access them quickly.
One other thing I wanted to mention about the hospice nurses and everything is they really educate the home caregiver about what to expect and what to look for in terms of death and when it's coming and what behaviors and things to watch out for. It does.
Yeah, knowing what's ahead and what to look for is really important. We do a lot of education with our patients and families.
Oh, in the back.
Many of you know my wife passed in March, and we used Good Sam during the last few weeks of her life. And I want to thank them publicly for the service that we got. It was great. And in response to some of the other questions about when to call someone in, if you think you need the service, you do. Don't hesitate. Don't wait too long. I think in my case, I waited longer than I should have in all candor. They're there. They have wonderful services of all kinds. Please make use of it if you think you're in need of it, because if you don't, you may find yourself regretting it a little bit later on. They're wonderful, and I thank them for their service to my wife.
That was a great lead-in for my question, because so long as I was alive, I was my husband's hospice. And I think that was a little bit unfair. So I would like to encourage all of you couples to have that conversation. And how long does it take to actually mobilize a hospice team?
I love that question, because I think that's one of the things we do the best at Good Sam. I tell you, last night we had a staff member that had a neighbor that was in a crisis and she was dying. We had a hospital bed out to her that night. He called me at 8:30. The hospital bed got in. We got medications in the home that night, and she was officially admitted within hours. So if it's urgent, if you need us now, we're going to do everything we can to make things happen. We get patients on our service within hours if it's needed. Yeah.
The palliative care unit in the hospital, Roanoke Memorial, I used that. I didn't even know it was my mother was in the hospital, and they said she wants palliative care. And I said, I don't even know what that is. He says, you just trust me. She does. And I said, okay. And it was wonderful. The difference was day and night. There wasn't any hospice that I know of, but the last week of her life was lovely at the hospital. and she was wonderfully cared for, much better than in the normal hospital area. So don't be afraid of using the hospital palliative care units. I imagine Lewis Gale has one?
Unfortunately, they don't.
Okay, I didn't know.
Our team does go over there, and we do provide consults at Lewis Gale. So our palliative team is in Lewis Gale as a consultant service. But when you speak of the palliative care unit at Roanoke Memorial, that's what we're trying to build by itself, but only better because it's going to be by itself and only focused on end-of-life care. Yeah. It is. Yes, it is. Yeah.
The other thing is, when you're on hospice, take advantage of all the services that they want to offer. I'm familiar with a family situation where the person was on hospice and a holiday weekend was coming along, and the hospice personnel offered to be available to this family. And the family said, no, go take the weekend off. And that's when the crisis happened. And when they decided to call hospice, hospice was a little short-staffed that weekend because they told that person to take the weekend off. And so allow hospice to do their work and do their staffing planning too.
Yeah, we're fortunate that we do have a full-time on-call team. So we have a team that's specifically for after hours. We're trying to build that up, but yes, we do have a team. We have all hours of the night, 24/7. Our team is available.
When three crises come up at the same time, you have to make sure.
Yeah, that's a little hard.
Do you support, or do you have support for the families after the loved one dies?
Absolutely, yes. We have bereavement counselors. We have bereavement services that last for 13 months or longer if you need them after the loved one dies. Yes.
Any other questions or comments? Okay.
Excuse me, could you define palliative care as you see it a little bit better? And when does a person or their family member need palliative care?
Sure, absolutely. I don't have the specific definition that we have in our book in my head, but palliative care is really the moment that you've been diagnosed with a life-limiting illness. So any type of cancer, any type of heart disease, any type of lung disease, liver disease, ALS, Alzheimer's, that's really the point that you could start getting palliative care. And really, it's a specialized team. It's just like a cardiologist or it's an orthopedic doctor. It's a specialist that works with your primary care doctor just for added support for you as you go down the journey with this disease. So it can be as when you're first diagnosed till you've been living with this disease for 3 years and you just need some extra support.
Okay, the reason I asked is my husband was here at Brandon Oaks with me for quite a while, and the term palliative care was tossed around in our family, and apparently it was just getting off the ground at Carilion. And I never really did understand what it was all about, but they didn't have it, so anyway, thank you.
Yeah.
Any other questions or comments? Yes.
Years ago, when I lost a very important friend, I was able to go to the support group, even though the person had never been on Good Sam. So I think that's an important service you offer to the community.
And just to add on to that, we have actually brought our services here. I know Olive and a few others attended, and it was so powerful, and it was right in the heart of the pandemic. But That is something that we are happy to do, and we can personalize it. You know, as the holidays approach, managing love and loss and feelings and emotions during the holidays, we can personalize that and bring that to you all. Any other questions or comments? I do know that I would love to take all of you all with me. You would make my job so much easier. I'm in awe and I have goosebumps with just the heart and passion and advocacy that you all have. It really, really touches me. So thank you all. And I might come and take a few of you all with me. It would make my job easier.
Dr. Easterday, Emily, thank you. Not only thank you for being here today, but thank you for what you do. It makes a huge difference, and it's extremely important. Thank you. I just really appreciate it. Thank you.